Welcome everyone to our lecture on the respiratory system. Today's topic is one of the most essential systems in the human body. This is responsible for something so automatic that we often don't even notice it until we are short of breath. The respiratory system is not just about inhaling oxygen and exhaling carbon dioxide. It plays a crucial role in maintaining the body's pH balance, vocalization, and protecting us from environmental contaminants through specialized structures. This lecture will focus on giving you a solid foundation in the understanding of the anatomy of the respiratory system, with a particular emphasis on the lungs, which are the primary organ for gas exchange. We'll also explore the forces that drive breathing, why air moves in and out of the lungs, and touch on how the complex systems develop during embryonic growth. Let's take a moment to review the learning objectives for today's lesson. These concepts will help guide our focus and ensure you're keeping track of the key concepts as we move through the material. First, we're going to list the structures of the respiratory system. Then we'll describe the major function of the respiratory system and also explain the forces behind air movement in and out of the lungs. And lastly, we'll outline the embryonic development of the respiratory system. Let's take a deeper look at why breathing is so critical and what really drives it. Breathing is so essential. Oxygen is needed for ATP, and carbon dioxide must be removed. It is this buildup of carbon dioxide, not the lack of oxygen, that primarily triggers breathing. The respiratory system includes these muscles, the airways, and the gas exchange that happens at these surfaces. It also plays along with the circulatory system, which helps transport those gases between the lungs and the body tissues. Ultimately, there's a wide range of respiratory diseases that can interfere with this process. Conditions like asthma, emphysema, chronic obstructive pulmonary disease or COPD, and lung cancer all disrupt gas exchange. This leads to a labored breathing, decreased oxygen delivery to the tissues, and buildup of waste gases in the body. Understanding the structure and function of the system is essential not only for basic biology, but also for recognizing how diseases impair one of our most vital processes, the exchange of gas that keeps us alive. Now let's talk about the lungs. These are the primary organs of the respiratory system, located in the thoracic cavity. They house both the conducting and the respiratory zones. The conducting zone is where air moves in and out of the respiratory tract, and the respiratory zone is where actual gas exchange occurs. This division allows for efficient filtering, humidifying, and delivery of air before it reaches the delicate alveolar surfaces. The lungs' main function is to bring in oxygen, which is essential for cellular respiration, and expel carbon dioxide, which is a metabolic waste product. What's truly remarkable is that the surface area available for this process, which is about 70 square meters, or roughly the size of a tennis court. The vast surface area is due to the presence of millions of alveoli, which are surrounded by a dense capillary network, ensuring maximum gas exchange efficiency. In addition to being highly permeable to gas, the lungs are also highly vascularized, meaning that they have an abundant blood supply to transport gases quickly to and from tissues. The pulmonary circulation brings deoxygenated blood to the lungs and returns oxygenated blood to the heart for systemic distribution. The lungs do not function in isolation. They rely on the diaphragm and the intercostal muscles to drive ventilation, and they work in partnership with the circulatory system to transport gases through the body. So as we study the lungs in great detail, keep in mind their central role in maintaining life, supporting metabolism, and connecting the external environment with the internal cellular function. They are much more than just bags of air. They are dynamic, responsive, and finely tuned organs essential for our survival. Now that we understand the overall function of the lung, let's take a closer look at the gross anatomy, or the visible structures. The lungs are asymmetrical, primarily because of how the heart is positioned in the thoracic cavity. The right lung is larger and has 3 lobes, the superior, the middle, and the inferior. They are separated by two fissures: the horizontal fissure, which separates the superior and middle lobes, and the oblique fissure, which separates the middle and the inferior lobes. In contrast, the left lung has two lobes, superior and inferior, divided by a single oblique fissure. The left lung is smaller because it accommodates the heart, specifically through a curved depression known as the cardiac notch on the medial surface. This anatomical feature makes room for the apex of the heart as it projects into the left pleural cavity. Each lung has several surfaces that will help define its position in relationship to the thoracic structures. The apex is positioned superior portion that extends slightly just above the level of the first rib. The base rests on the diaphragm. The costal surfaces faces the ribs and intercostal muscles. The mediastinal surface faces inward towards the heart and great vessels. The hilum is centrally located. The concave area on the mediastinal surface where structures such as the pulmonary bronchi, pulmonary artery and veins, lymphatic vessels, and nerves enter and exit the lungs. Together, these structures are called the lung root, and they anchor the lung to the mediastinum. Each lung is divided into lobes, which we've already discussed. The right lung has 3 lobes, and the left lung has 2. Each lobe is further subdivided into bronchopulmonary segments. These segments are important because they are functionally and anatomically distinct regions, each receiving air on its own tertiary bronchus and blood from its own branch of the pulmonary artery. This means that each segment operates somewhat independently. Clinically, this is very helpful. If a disease like tuberculosis or cancer is limiting a single segment and can sometimes be surgically removed without affecting adjacent healthy segments. Going even smaller, each bronchopulmonary segment is divided into multiple pulmonary lobules. A lobule is the smallest visible subdivision of the lung and is supplied by a single bronchiole. The lobules are separated by a thin wall of connective tissue called interlobular septa. These help organize airflow and limit the spread of infection or damage. This hierarchical structure from lobes to segments to lobules not only improves respiratory efficiency, but also creates compartmentalization that aids in managing injury and disease. Now let's turn our attention to how the lungs receive blood and how that blood supports the critical functions of gas exchange. Blood reaches the lungs via the pulmonary arteries, which is the branch of the pulmonary trunk coming from the right side of the heart. It's important to remember that even though these are arteries, they carry the oxygenated blood because in the lungs, the job is to pick up oxygen, not deliver it. As the pulmonary arteries enter the lungs, they branch repeatedly, following the branching patterns of the bronchi. These vessels narrow into arterioles and eventually into dense network of pulmonary capillaries that wrap around each alveolus. This is where gas exchange occurs. Oxygen diffuses from the alveoli into the capillaries. Carbon dioxide diffuses from the capillaries into the alveoli for exhalation. Together, the thin walls of the alveoli and the capillaries form a respiratory membrane, which allows for rapid diffusion of gases due to its thin, delicate structure. Once the blood is oxygenated, it flows into the pulmonary venule, then into the pulmonary veins, which carry the blood that is now oxygen-rich back to the left side of the heart. From there, the blood is pumped out to the rest of the body to deliver oxygen to the tissues. Each pulmonary lobule is serviced by its own arteriole and venule, which allows for efficient and localized gas exchange within smaller regions of the lung. This dual vascular and respiratory design supports the high metabolic demand of the human body and ensures that oxygen and carbon dioxide can be exchanged quickly and efficiently with every breath we take. In addition to the mechanical and vascular components of the lung, nervous control plays a major role in regulating airflow and respiratory reflexes. The autonomic nervous system governs the diameter of the airways, which directly influences the amount of air reaching the alveoli. There's 2 main branches involved. The parasympathetic nervous system, primarily through the vagus nerve, causes bronchial constriction. This narrows the airway, which can help conserve heat and moisture or limit the entry of irritants. In contrast, the sympathetic nervous system causes bronchodilation, which is the widening of the airways to increase airflow. This is particularly important during exercise and stress, and the body needs more oxygen. The autonomic nervous system also controls various reflexes such as coughing and helps regulate oxygen carbon dioxide levels in response to chemoreceptors located in the respiratory tract and the central nervous system. Sensory innervation of the lungs comes from two main sources: the vagus nerve or cranial nerve 10, which carries both motor and sensory fibers. The second to fifth thoracic spinal nerves, T2 through T5, also contribute sensory input via sympathetic pathways. All of the fibers converge in the region of the hilum known as the pulmonary plexus. From there, the nerves branch along the bronchi into the lungs, innervate smooth muscles, glands, and blood vessels. This complex neural control allows the lungs to adapt quickly to changes in the body's activity, environment, or health issues, making it critical to the flexibility and responsiveness of the respiratory system. Finishing our overview of the lung anatomy, let's focus on the pleura, the thin double-layered serous membrane that surrounds each lung. Each lung is enclosed in its own pleural sac, which has two continuous layers: the visceral pleura and the parietal pleura. The visceral pleura adheres directly to the surface of the lungs, even extending into the fissures between the lobes. The parietal pleura lines the inside of the thoracic wall, the superior surface of the diaphragm, and the lateral walls of the mediastinum. Between these two layers is the pleural cavity, a thin potential space filled with a small amount of serous pleural fluid. This fluid is produced by mesothelial cells and serves several important functions. First, the fluid acts as a lubricant, greatly reducing friction as the lungs expand and contract against the chest wall during breathing. This ensures that the movement is smooth and pain-free. Second, the fluid creates a surface tension between the two pleural layers. This tension effectively sticks the lungs to the inner chest wall, allowing them to expand passively as the thoracic cavity enlarges during inhalation. Without the surface tension, the lungs would collapse. Third, the pleura compartmentalizes the lungs, physically separating them from each other and from each other organ in the thoracic cavity. This structural division helps protect the lungs by minimizing mechanical interference by limiting the spread of infection between the adjacent organs. Damage to the pleura, such as pleurisy or a pneumothorax, can impair lung function dramatically. Understanding the membrane system is therefore crucial for diagnosing and managing respiratory conditions. The conducting zones include all the airways that bring air into and out of the lungs but are not involved in gas exchange themselves. In contrast, gas exchange only happens in the respiratory zone, which includes the alveoli and associated structures. Think of the conducting zone as the transport system for incoming air and outgoing air. This part of the respiratory system serves several critical roles beyond simply moving air. In fact, as a filter, trapping pathogens, debris, and particulate matter before they can reach the delicate surfaces of the alveoli. It warms and humidifies the air to prevent damage to internal lung tissue, which is highly sensitive to dry or cold air. It also facilitates olfaction, or the sense of smell, through specialized epithelial structures in the nasal cavity. It plays a vital role in vocalization, particularly in the larynx where vocal cords are housed. It also initiates reflexes like sneezing or coughing, which protects the respiratory tract from harmful substances or irritants. The conducting zone is lined primarily with a ciliated pseudostratified columnar epithelium, which contains goblet cells that produce mucus. This mucus traps airborne debris. The cilia beat rhythmically to sweep it upwards and out, forming what is known as the mucus escalator. Ultimately, the conducting zone ensures air is properly conditioned and cleaned before it reaches the respiratory zone, making it essential for efficient and safe gas exchange. Now that we understood the purpose of the conducting zone, let's identify the major structures that it makes up. The conducting zone is made up of both upper and lower respiratory tract structures. The upper respiratory tract structures include the nose and nasal cavity, which are the primary external entry points of air. These structures filter, warm, and humidify air and house olfactory receptors for the sense of smell. It also includes the paranasal sinuses, which are air-filled cavities in the skull bones that also help warm and moisten air and add resonance to our voice. The pharynx, which is a muscular tube that connects the nasal cavity and the mouth to the larynx and the esophagus, which is further subdivided into three regions: the nasopharynx, which is air only, the oropharynx, and the laryngopharynx, which is both air and food. The lower respiratory tract includes the larynx, also known as the voice box, which also regulates airflow, protects the airway from ingested materials, and enables vocalization. The trachea, which is a rigid cartilaginous tube that carries air from the pharynx into the thoracic cavity. The bronchi, where the trachea splits into the right and left pulmonary bronchi, which further branch into the secondary and tertiary bronchi. The bronchioles, which are small airways which are less than a millimeter in diameter that branch from the bronchi and continue dividing into until they reach the terminal bronchioles, which mark the end of the conducting zone. While these organs vary in size and shape, they all serve the same shared purpose of conducting air towards the alveoli while filtering, humidifying, and regulating airflow. In addition, the lining of these structures plays a vital defensive role, helping prevent pathogens and debris from reaching the delicate gas exchange surfaces. Let's begin our journey through the conducting zones with the nose and the nasal cavity, which serve as the primary entrance for the respiratory system. The external nose is made up of nasal bone at the bridge and several pieces of hyaline cartilage, including the lateral cartilage, alar cartilages, and the septal cartilage. These structures give the nose its shape and flexibility. When looking at a skull, much of the nose is missing because the cartilaginous components do not preserve post-mortem. Entering the nose opens into the nasal cavity, which is separated into the right and left halves by the nasal septum. The septum consists of cartilage anteriorly and ethmoid and vomer bones posteriorly. Along each lateral wall of the nasal cavity are three bony projections called nasal conchae, the superior, middle, and inferior. These conchae increase surface area and create turbulent airflow, which help trap particles in the mucus and slow the air down to allow more effective warming and humidifying. The entire nasal cavity is lined with respiratory epithelium, a ciliated pseudostratified columnar epithelium with goblet cells that secrete mucus. Cilia move trapped debris posteriorly towards the pharynx, where it can be swallowed. The function of the nose and nasal cavity are multifaceted. They filter out dust and pathogens, warm and moisten incoming air to protect the lower airways. They detect odors via specialized olfactory receptors at the roof of the nasal cavity and serve as resonating chambers that enrich vocal tone. Additionally, skin-lined nasal vestibules just inside the nostrils contain hair and sebaceous glands to block large particles. This complex and efficient entry system prepares air for its journey deeper into the respiratory tract. The paranasal sinuses are a group of air-filled spaces found within the bones surrounding the nasal cavity. Although small in size, they contribute significantly to respiratory function and voice production. Each sinus is named after the bone in which they reside. The frontal sinuses are located just above the eyebrows within the frontal bone. The maxillary sinuses are the largest and are found beneath the eyes of the maxillary bone. The sphenoid sinuses sit within the sphenoid bone near the base of the skull. The ethmoid sinuses or ethmoid air cells consist of many small cavities located between the nasal cavity and its orbits. All of these sinuses are lined with the same respiratory epithelium found in the nasal cavity, ciliated stratified columnar epithelium with mucus-producing goblet cells. They drain into the nasal cavity and, to function properly, they help maintain clean and humidified air passages. The function of the paranasal sinuses include reducing the weight of the skull, making the head easier to balance and support, conditioning inhaled air by warming it and humidifying it, acting as a resonance chamber for voice amplification, which is why our voices sound different when we are congested, helping to protect the brain by absorbing and distributing force during the facial trauma. Because their drainage openings can be small and located high within the sinuses, they are prone to blockage and infection. This is especially true for the maxillary sinuses, which often remain filled during proper respiratory tract infections, leading to sinusitis, which is characterized by facial pressure, headaches, and nasal congestion. The respiratory epithelium is the specialized lining that plays a central role in airway defenses and conditioning. You'll find it throughout much of the conducting zones, including the nasal cavity, paranasal sinuses, nasopharynx, larynx, trachea, and bronchi. It's made up of ciliated pseudostratified columnar epithelium, which appears layered due to the varied positions of the nuclei, but is actually a single layer of cells. Two key features of the epithelium are the goblet cells, which produce mucus, a sticky secretion that traps dust, allergens, bacteria, and other foreign particles, and cilia, which are hair-like projections that peat rhythmically to move the mucus upwards to the throat, a process known as mucus escalators. This mechanism is crucial for respiratory hygiene. It constantly clears the airway of debris and pathogens by sweeping them towards the pharynx, where the mucus can be swallowed into the stomach and neutralized by stomach acid. Just beneath the epithelium lies a layer of immune cells and blood vessels. These help warm the incoming air by convection, provide local immune surveillance, and respond quickly to pathogens. It is important to note that cold temperatures can slow the movement of cilia. This is one reason people tend to get runny noses in cold weather. Mucus production continues, but ciliary movement slows, leading to mucus accumulation. This epithelium is the first line of defense and essential for keeping the lower respiratory tract sterile and functional. The pharynx is a muscular passageway that plays a dual role in the respiratory and digestive system. It conducts air to the larynx and food to the esophagus, making it a critical crossroad in the throat. It's divided into three distinct regions. The nasopharynx, which is located directly posterior to the nasal cavity, it serves exclusively as an airway and is filled with ciliated pseudostratified columnar epithelium. The uvula and soft palate rise during swallowing to block this region and prevent food or liquid from entering the nasal cavity. It also houses the opening of the auditory or eustachian tubes, which help equalize pressure between the middle ear and the atmosphere. The oropharynx, which is located behind the oral cavity, serves as a passageway for both air and food and is lined with stratified squamous epithelium to resist mechanical abrasions from the food. This region includes the palatine tonsils, which play a role in immune defense, and the laryngopharynx, which is the most inferior portion located just behind the larynx. It continues the dual function of air and food passage, ending where the passages diverge. Air continues into the larynx, food enters the esophagus. This area is also lined with stratified squamous epithelium for protection. Altogether, the larynx helps to guide air from the nasal cavity towards the lower respiratory tracts while participating in speech resonance, immune protection, and swallowing mechanics. Next, we arrive at the larynx, commonly referred to as the voice box. This cartilaginous structure serves several important functions: airway passage and protection. The larynx connects the laryngopharynx to the trachea to help direct air into the lower respiratory tract while protecting the airway from swallowed materials. And in protection, the epiglottis, which is a flexible flap of elastic cartilage, covers the glottis during swallowing. This action prevents aspiration, the entry of food or liquids into the trachea. Voice production. Within the larynx lies the glottis, which includes the true vocal cords or the vocal folds, which are white elastic folds that vibrate to produce sounds when air passes through them, and the vestibular folds or the false vocal cords. These are located above the true cords, which play a role in resonance and protection. The space between the folds in the glottic opening where the air flows into the trachea. The thyroid cartilage forms the bulk of the anterior wall and includes the laryngeal prominence, commonly known as the Adam's apple. The cricoid cartilage forms a complete ring inferior to the thyroid cartilage, helping maintain the airway open. Two arytenoid cartilages located posteriorly are responsible for adjusting the tension and position of the vocal cords. By moving these cartilages, intrinsic laryngeal muscles change the pitch and voice and volume. The tighter, the longer the chords, the higher the pitch. The looser, the shorter the chords, the lower the pitch. This vocal function is supported by airway and pressure changes created by the lungs and the diaphragm. It is also worth noting that males typically have longer, thicker vocal cords, which leads to deeper voices. The larynx is lined with stratified squamous epithelium in regions exposed to abrasions and transition to respiratory epithelium below the vocal folds. Now we follow the airway below the larynx into the trachea, commonly known as the windpipe. This vital structure conducts air towards the lungs and is built for both support and flexibility. The trachea extends from the cricoid cartilage to the larynx down to the carina, where it branches into the right and left pulmonary bronchi. It is approximately 10 to 12 centimeters long and lies anterior to the esophagus. The tracheal wall is composed of several layers. Mucosa, which is the innermost lining, features ciliated pseudostratified columnar epithelium with goblet cells. This epithelium helps trap debris in mucus and uses a mucus escalator to sweep it towards the pharynx for removal. The submucosa, this layer houses the seromucous glands, which contribute to additional lubricating secretions to moisten and trap particles in the airway. Cartilage, which the trachea is supported by 16 to 20 C-shaped rings of hyaline cartilage. These rings keep the airway open during both inhalation and exhalation. The open portion of the C faces posteriorly towards the esophagus. Then we have the trachealis muscle. This band of smooth muscle connects the open ends of the cartilage ring. It allows the trachea to contract slightly during coughing and expel air forcefully, and also accommodates the expansion of the esophagus when swallowing food. The adventitia, which is the outermost layer, is composed of dense connective tissue and anchors the trachea to surrounding tissues. The structures of the trachea ensure a clear and protected passageway for air to move into the bronchi. The balance of rigidity from the cartilage and flexibility from the muscle and connective tissue allows it to function effectively as both a conduit and a dynamic part of the respiratory defense. As we move deeper into the conducting zones, we reach the bronchial tree, a branching network of airway that distributes air throughout the lungs. The trachea bifurcates at the ridge called the carina, which contain sensitive receptors that trigger coughing when initiated. From this point, the airway divides into the primary or the main bronchi and the secondary bronchi. The primary bronchi, one for each lung. The right bronchus is wider, shorter, and more vertical than the left, which is why inhaled objects more often enter the right lung. The secondary or lobar bronchi these branch off the primary bronchi and supply the air to each lobe of the lung. The right lung has 3 lobar bronchi, and the left has 2. The tertiary or segmental bronchi branch from the lobar bronchi and supply air to the bronchopulmonary segments, which are functionally independent units of the lung. As the bronchi continue branching, their walls change structurally. The epithelium remains ciliated pseudostratified columnar epithelium with goblet cells, but the cartilage rings become more irregular and decrease in quantity and size as the bronchi get smaller. Smooth muscle contents also increases, allowing for greater control over bronchial diameter. This muscular control is especially important in regulating airflow through the bronchoconstriction and bronchial dilation, which are influenced by the autonomic nervous system and input the inflammatory signals. The bronchial tree ensures that air is eventually distributed across the lungs that remain filtered, warmed, and humidified throughout its journey towards the alveoli. Now we've reached the smallest passage of the conducting zone, the bronchioles and terminal bronchioles, which marks the transition into the respiratory zone where gas exchange occurs. As bronchi branch and become progressively smaller, they eventually lose their cartilage support and transition into bronchioles, which are less than 1 millimeter in diameter. Unlike bronchi, bronchioles lack cartilage, making them more flexible but also more prone to constriction or obstruction, as seen in the conditions like asthma. The epithelium in bronchioles change from ciliated pseudostratified columnar to simple columnar and eventually into simple cuboidal, in the smallest bronchioles. Goblet cells are reduced or absent. Cilia become sparse and may disappear altogether in the terminal bronchioles, limiting mucus clearance in these regions. Despite this, bronchioles play a critical role in airflow regulation thanks to their thick layers of smooth muscle. Bronchial constriction or narrowing reduces airflow and can be triggered by the parasympathetic input, allergens, or cold air. Bronchial dilation, which is widening, is promoted by the sympathetic stimulation in medications like inhaled beta agonists like albuterol. At the very end of this branching network are terminal bronchioles, which represent the final portion of the conducting zone. Each terminal bronchiole delivers air into the respiratory bronchioles, which begin the respiratory zone where alveoli first appear and gas exchange can occur. Each lung contains approximately 30,000 terminal bronchioles, providing a vast surface area for distributing air evenly into the lungs. Understanding these final branches is crucial as they serve as the gateway for gas exchange. Their structures, flexibility, and regulation are essential for maintaining proper ventilation and ensuring that oxygen reaches the alveoli effectively. Now we begin our discussion on the respiratory zone, which is the functional portion of the respiratory system where gas exchange occurs. This zone begins at the point where the terminal bronchiole, the last structures of the conducting zone, give rise to the respiratory bronchioles. From there, the pathway continues through the alveolar ducts, ending in clusters of alveolar sacs made of individual alveoli. Unlike the conducting zones, which merely transport warm and filtered air, the respiratory zone allows for oxygen to enter the blood and carbon dioxide to exit. This is possible due to the thin, permeable walls of the respiratory structures, which allows for diffusion of gases along the respiratory membrane. This tissue lining structures changes as we go deeper. Respiratory bronchioles are lined with simple cuboidal epithelium. Alveoli are lined with simple squamous epithelium, ideal for diffusion. The respiratory zone provides an impressive surface area for gas exchange, up to 70 or even 80 square meters in healthy adults. This expansive area is made possible by the millions of alveoli, each acting like microscopic balloons to maximize exposure to inhaled air. Continuing our journey through the respiratory zone, we now focus on the alveolar ducts and the alveoli, the final and most critical sites for gas exchange. After air passes through the respiratory bronchioles, it enters the alveolar ducts. These ducts don't have distinct walls of their own, but are formed by the openings of numerous alveoli. Each duct leads into a cluster of alveoli known as alveolar sacs. Each lung contains about 480 million alveoli, which collectively provide the mass surface area needed for efficient gas exchange. Comparable to the size of a tennis court, these alveoli are lined with simple squamous epithelium, the tiniest possible type of epithelial tissue, which facilitates rapid diffusion of oxygen and carbon dioxide. One key structural feature of alveoli is the presence of alveolar pores. These tiny openings allow air to pass between adjacent alveoli, helping to equalize pressure throughout the lungs and improve ventilation. Another important feature is the elasticity of the alveolar walls. During inhalation, alveoli expand like small balloons. During exhalation, they recoil to help push out air out of the lungs. This elastic property is essential for efficient breathing. Each alveolar sac is enveloped by a capillary network where deoxygenated blood from the pulmonary arteries arrives as reoxygenation. This close proximity between the alveolar walls and the capillaries sets the stage for the respiratory membrane, which we will explore more. The respiratory membrane, which is the actual interface where gas exchange occurs between the air and the blood. This incredibly thin membrane, approximately 0.5 micrometers thick, is composed of 3 layers. Type 1 alveolar cells lining the inner surface of the alveoli. These are extremely thin squamous epithelium that make up about 97% of the alveolar surface. A shared basement membrane which fuses the alveolar epithelium and capillary endothelium into a single ultra-thin layer to minimize diffusion. The capillary endothelium made up of simple squamous cells that line the blood vessels. Together, these layers create a smooth, low-resistance pathway through which oxygen diffuses from the alveolus into the blood, and carbon dioxide diffuses out of the blood into the alveolus. This structure is perfectly optimized for simple diffusion, allowing gases to move passively down their concentration gradients. The large total surface area for about 70 to 80 square meters ensures that enough oxygen can be transferred to meet the body's metabolic needs, even during exercise. Any thickening or damage to this membrane, such as from fluid buildup, as in pneumonia, fibrosis, or emphysema, can impair gas exchange and result in respiratory distress. Now let's take a look at the three major types of cells that make up the walls of the alveoli and support the function of the respiratory membrane. First, we have type 1 alveoli cells, known as type 1 pneumocytes. These are thin, squamous epithelial cells that make up about 97% of the alveolar surface. Their primary role is to facilitate gas exchange by forming a thin barrier through which oxygen and carbon dioxide can diffuse. They're extremely thin and about 25 nanometers thick to minimize resistance to diffusion. Next, type 2 alveolar cells, or type 2 pneumocytes. These are cuboidal in shape and are scattered among type 1 cells. Their most critical function is to secrete pulmonary surfactant, a liquid protein substance that reduces surface tension within the alveoli. This surfactant prevents alveolar collapse during exhalation and ensures that the lungs can reinflate easily within the next breath. Type 2 cells also play a role in alveolar repair if injury occurs. Finally, we have alveolar macrophages, also known as dust cells. These are mobile immune cells that crawl along the alveolar surface, engulfing inhaled particles, microorganisms, and dead cells. Because the alveoli are the deepest part of the lungs and directly open to the outside environment, macrophages are essential for maintaining clean and functional surfaces for gas exchange. Together, these three cells form a highly specialized microenvironment that supports not only the exchange of gases but also immune protection and tissue maintenance. Now, let's focus our attention on the muscles involved in breathing, also known as pulmonary ventilation. First, it is important to understand that the lungs themselves are passive structures, meaning they do not actively contract or expand on their own. Instead, ventilation is driven by changes in thoracic cavity volume, which in turn changes the pressure within the lungs, allowing air to move in and out. During quiet inspiration or normal inhalation at rest, the diaphragm contracts and flattens, increasing the vertical dimension of the thoracic cavity. At the same time, the external intercostal muscles contract, lifting the ribs cage upwards and outwards. Together, these movements expand the thoracic cavity, decrease internal pressure, and draw air into the lungs. During quiet expiration, this process is passive. The diaphragm and intercostals retract and relax, and the elastic recoil of the lungs and thoracic cavity thoracic wall naturally decreases lung volume, pushing air out. Now, during forced breathing, such as during exercise or stress, additional muscles are recruited. Inspiration is assisted by the sternocleidomastoid, scalenes, and pectoralis muscles, which further elevate the ribs and expand the chest. Expiration becomes active, involving the internal intercostals, which pull the ribs downward, and the abdominal muscles, which push the abdominal contents up against the diaphragm to force air out more rapidly. Understanding these muscle mechanics is key to interpreting respiratory disorders, physical training, and even mechanics for artificial ventilation. In COPD, or chronic obstructive pulmonary disorder, which are a group of progressive diseases that severely affect ventilation and gas exchange, COPD primarily has two conditions: chronic bronchitis and emphysema. In chronic bronchitis, which is characterized by long-term inflammation of the bronchioles, narrowing the airway lumen, this condition is often accompanied by overproduction of mucus, which further blocks airflow. Patients typically have chronic cough and difficulty clearing mucus from the lungs. Emphysema involves the destruction of alveolar walls, leading to fewer but larger alveoli. This reduces the surface area available for gas exchange. The elastic recoil of alveoli is lost, impairing expiration and trapping air in the lungs. Both conditions reduce the efficiency of oxygen uptake and carbon dioxide removal. As a result, patients often experience shortness of breath, chronic fatigue, and several cases of respiratory failure. You might be surprised to learn that not all COPD patients are smokers, though tobacco use is the leading risk factor. Other causes include long-term exposure to air pollutants or occupational irritants. Treatment typically involves bronchodilators to open up the airways in the form of an inhaler, anti-inflammatory drugs like corticosteroids, supplemental oxygen therapy for advanced cases. Even with treatment, COPD is a progressive disease, meaning symptoms worsen over time. Early diagnosis and management are key to improving quality of life. Breathing might feel automatic, but it is under precise neural control, managed by centers in the brainstem, specifically the medulla oblongata and the pons. The medullary respiratory centers are responsible for setting the basic rhythm of breathing. These centers respond primarily to the levels of carbon dioxide in the blood, which is tightly linked to blood pH. Even small changes in carbon dioxide can cause rapid adjustments in the respiratory rate. This control is mediated by chemoreceptors. The central chemoreceptors in the brainstem monitor pH of cerebrospinal fluid, which reflect carbon dioxide levels. Peripheral chemoreceptors located in the aortic arch and the carotid arteries sense changes in blood carbon dioxide pH, and only under extreme condition, oxygen levels. When carbon dioxide builds up or blood becomes too acidic, the medulla signals respiratory muscles to increase breathing rate, helping to expel more carbon dioxide and restore pH balance. Interestingly, we can override this automatic control temporarily. You use voluntary control when singing, speaking, or holding your breath. However, if carbon dioxide levels rise too much during voluntary breath holding, the autonomic system takes back control, forcing you to breathe. The normal respiratory rate varies with age. In adults, it's typically 12 to 18 breaths per minute, though it may increase with exercise, stress, or illness.